morning, students. Today we are going to discuss very important topic of physiology, that is respiratory physiology, high altitude physiology. We have discussed all the respiration in detail according to the normal basal metabolic rate. Now we are discussing what happens to these particular systems when they are at their extremes. So in the next coming lectures, we will discuss what actually the respiratory system is going to react when they are at their extreme levels. So in this particular session, we are discussing the high altitude physiology. Now to see before going into details of this, what happens at the high altitude, let us discuss. The barometric pressure falls with increasing altitude, that we all know. But the composition of the air will always remain same. So these are very important points which you have to remember. Now according to the Dalton's law, whatever the total pressure of air, that will be actually the sum of partial pressure of all the gases. So what pressures of that particular gases are there, sum of all these partial pressures will be the total pressure of air at whatever altitude. And the major pressures which are contributing to the total pressure are oxygen, carbon dioxide, nitrogen and water. Now water and carbon dioxide, these are determined by the body. So they will not change with altitude. As the metabolic production of the carbon dioxide as well as the water does not alter with increasing altitude, the alveolar PCO2 will always remain same. It will not change. So there will be change, but when the body metabolism are going to change, they will change the pressure of carbon dioxide, they will change the pressure of water. But at high altitudes, the metabolism is not hampered, and that is why these pressures will not be changed. So the pressures which are going to change are only the partial pressure of oxygen and the partial pressure of nitrogen. Now amongst these two, as the oxygen is the major pressure which is contributing to the total pressure of air, we are going to consider what will happen to this oxygen and the partial pressure of oxygen and how does it affect the respiration. Now, why you want to study this particular high altitude respiratory physiology? Because it is important in cases of mountaineering. We study also the aviation. Nowadays, space flights are very common. There are some permanent human settlements at highlands. We want to study their body parts, and that these respiratory physiology at high altitude is very commonly seen for these particular things. Now, Paul Bert, he was the first French physiologist who recognized that at high altitude there are some harmful effects which are due to low oxygen tension. So he was the first person who said that at high altitude there is no oxygen tension, and due to these there are harmful effects. So since then we are studying all these things, and now what is the doctor's role is to prevent this complication. So what are the different pressures and what will be the partial pressures? As we are going to discuss only the oxygen, here in this particular table, the oxygen pressures are given. So if you consider the sea level, the atmospheric pressure is around 760, we know. The arterial pressure is around 100 of oxygen. The venous pressure is 40. The pressure difference will be 60 and the saturation will be 98%. Hemoglobin will be saturated with oxygen. That means normal amount of oxygen is to be delivered to all the tissues. So there is no problem. But as you see, as the altitude goes on increasing, it also decreases the atmospheric pressure. The content, of course, will be changed is the oxygen partial pressures. So at arterial level, you can see there are drastic changes in the arterial partial pressure of oxygen, whereas the venous pressure also goes on decreasing. And as these both are changed, the pressure gradient, which is important for the oxygen transport, that also goes on decreasing. And this affects the saturation of hemoglobin, it decreases the oxygen carrying capacity, and thus it reduces the amount of oxygen which is delivered to the tissues, and that will cause the harmful effects. So if you consider this 25,000, Here the atmospheric pressure is around 282. The arterial pressure is 7, so much reduced. See, from 100 it has been decreased up to 7 only. And then the venous pressure, if you consider, it is only 4. So the gradient will be 3. And due to with this pressure gradient, only 9% of hemoglobin will be saturated with oxygen. So very less amount, very negligible amount can be delivered to the tissues. So these are the altitude changes and the partial pressures which are measured. You have to remember what are the critical altitudes physiologically. Up to 10,000 feet, it is known as high altitude and it is considered as safe zone of rapid ascent. Around 18,000 feet, the upper limit is there, and up to that level, permanent human inhabitation is possible. So there are some tribes which live at these particular heights. So in the mountains, in the Himalayas, you will see that around these heights, somewhat human inhabitation will be there. Above 20,000 feet, life is endangered without supplemental oxygen. More than that, up to 30,000 feet, oxygen supplement is must. It is known as critical survival altitude. So these heights are very much important. Those who are interested in the mountaineering, they will understand it more better. So if you are thinking of these, there are so many groups of students with the doctors. There are some NGOs also, those who are interested in mountaineering. They will have all these knowledge. That is up to 30,000 feet, it is critical survival altitude. From 40,000 feet onwards, the ozone layer starts. So beyond that, the human inhabitation, of course, beyond 18,000 feet, it is not possible. But with the help of oxygen supplement, at some level, you can survive. Normally, the Mount Everest, which is the highest peak point, it is around 8848 meters now height, that is around 30,000, 29,028 feet. Here the atmospheric pressure is around 255 millimeters. It is less than half. The partial pressure will be 53 millimeters and inspired partial pressure of oxygen is only 44 millimeters of mercury. So if a person who is not acclimatized to these conditions, an unacclimatized person will be unconscious within 45 seconds at this particular height, and he or she will be dead in 4 to 6 minutes. So that is because there is no delivery of oxygen at these heights. Now, after knowing all these pressure changes, there are some facts we should remember that around 8,000 feet, the commercial planes are flying. So these are some things which we have to remember because as the human beings, we follow all these technological things also. So commercial plane fly at around 8,000 feet. The skydivers, they are diving around 15,000 feet is the height. Military aircraft, they can fly up to 50,000 feet heights. Helicopters, they will fly around 6,000 feet. Now you have to remember what should be the partial pressure, what should be the saturation at these particular levels, and what complications can occur at these particular heights and how you are going to treat these conditions. So in 1936, Francis Swain of the Royal Air Force reached around 49,970 feet, that is around 50,000 feet, flying a Bristol type of 138 while wearing a pressure suit. So he was wearing a pressure suit, and with the help of these pressure suit, that particular plane he was riding, and he was able to ascend up to 50,000 feet. So this was the first reported case long back in 1936. 2 years later, Italian military officer Mario Pezzi set an altitude record of more than that, that is around 56,000 feet, wearing a pressure suit, but now in the open cockpit plane. So it was 2 years later, 1938, and since then, the scientists, the Air Force, all are very much interested in how we can achieve these particular heights without any harmful effects. The highest current world absolute general aviation altitude record till last year, it was 123,520 feet. So 1,23,520 feet was the record rate up to last year. I have checked this up to last year, said by Alexander Fedotov on 31st August 1977. Now, after that, there was no record breaking of this general aviation altitude record. So, without any harmful effect, he was able to ascend up to these heights. So, up to 29,000 feet, the highest level at which the aviator can fly without oxygen. Highest level at which the aviator can fly with oxygen is 34,000 feet. In pressurized cabin with 100% oxygen, it can be possible up to 40,000 feet. And then when water boils at normal body temperature, the vapor density of water same as that of water, and that is known as Armstrong limit. And this Armstrong limit is 64,000 feet. So more than that, the water inside the body will start boiling. So these things, normal physiological changes, you will have to remember. And then if you are at all becoming a doctor in the military also, if you are Air Force doctor, then you will have to remember all these things. And this is known as Armstrong limit. So these are just the facts which you will have to remember why this particular chapter is important. Those who are interested can go for this. Now, what are the common hypoxic effects with different altitudes? So definitely at higher altitudes, we are facing the problem of hypoxia, that is less oxygen pressure, and it is causing the harmful effect. Now, what will be the effect? So if you see in the meters, in the feet, here we can see that it is sea level. If it is there, the inspired air will be 160, saturation is 97%, so there are no nil effects are there. If we are ascending up to 10,000 feet, the pressure will be decreased up to 110, but still the saturation is 90%, so it is safety zone, buffer zone, so there will be no complications are seen, but sometimes nocturnal visual reduction can be seen. Then more than that, that is around 10,000 to 15,000 feet if you are going, the pressure will now very much decrease, that is around 98%, the saturation is 80%, and here we will see moderately hypoxic symptoms, and these are drowsiness, headaches, mental and muscle fatigue. So at around these levels, with the pressure decrease, with less saturation, you are going to have the moderately hypoxic symptoms. More than that, 15,000 to 20,000 feet, drastic decrease in the pressure 70, and saturation will be less than 70%, and that creates severe hypoxic symptoms, which will lead to aggravated CNS involvement. So here these things will be warning signs, and with these warning signs, there will be CNS involvement causing seizures and muscle twitching. Above 20,000, further fall in the pressure occurs and the saturation goes below 60%, causing the person unconsciousness. There will be alarming deterioration. Survival is generally impossible without supplemental oxygen supply, and this is known, as we have seen in the earlier slide also, this is known as critical survival altitude. So you will have to have the supplemental oxygen to reduce all these complications. Now, what are the physiological responses to the high altitude hypoxia? These physiological responses are divided into two types. First, acute responses, which are known as accommodation, and second is long-term responses, which are known as acclimatization. So acute responses will be there, which is just accommodation, and secondly, long-term responses will be there. Accommodation refers to immediate reflex adjustments of respiratory as well as the cardiovascular system to hypoxia. Whereas acclimatization is referring to the changes in the body tissues in response to long-term exposure to hypoxia. Very commonly, the question again is asked in the examination. Now, what is accommodation? That is immediate reflexes. Now, there will be immediate reflex response of the body, and this is hyperventilation. So, as there is decrease in the arterial partial pressure of oxygen, stimulation of peripheral chemoreceptors will be there, and that will increase the rate and depth of breathing, and that results in hyperventilation. So this is the first immediate reflex response. Then there will be tachycardia. These peripheral chemoreceptors will also increase the cardiac output, and then they will increase the oxygen delivery to the tissues. So the peripheral chemoreceptor also cause tachycardia. The third important change is there will be increase in the 2,3 dpg concentration in the RBCs. Within hours, there will be increase in the deoxyhemoglobin concentration. That will increase the pH, that will increase the 2,3 dpg, and that reduces the oxygen affinity of hemoglobin. So you might be remembering the lecture of oxygen transport. Whenever there is increased pH, increased to 3 dpg, that decreases the oxygen affinity. That means there will be release of oxygen. So tissue oxygen tension will be maintained at higher than normal level. Neurological responses will be considered generally as warning signs. So there is depression of the CNS. So if someone is feeling lazy, sleepy, or it is having headache or complaining of headache, these should be considered as warning signs. Then there is a release phenomena like effect of alcohol, lack of coordination, release phenomena like effect of alcohol, lack of coordination, slurred speech, slow reflexes, and overconfidence. So if a mountaineer is showing all these neurological signs, they should be considered as warning signs. At further heights, there will be cognitive impairment, poor judgment. So the person will not be able to take any decision. Muscle twitching is seen. There is convulsions many times, and finally it will lead to unconsciousness. So these all will be immediate responses which are known as accommodation. Now coming to the acclimatization, which are a chronic response to the high altitude. So what will be the changes? Now the body will try to adjust at this height. So that is causing some physiological readjustments, and compensatory mechanisms in the body will reduce the effect of hypoxia. They will try to reduce the effect of hypoxia. So whatever compensatory mechanism, they will be activated. And then in the permanent residents at high altitude, they will reduce the effect of hypoxia like this, and that is known as acclimatization. Now it is done by a great increase first in the pulmonary ventilation. Second is there will be increase in the diffusion capacity of the lung. There will be increased ability of the tissue cells to utilize the oxygen, and there will be increased vital capacity. So all these four changes in the respiratory system: increase in ventilation, increase in the diffusion capacity, increase utilization of oxygen, and increase vital capacity. So all these physiological readjustments will be as a compensatory mechanisms acclimatized person will show. You can see respiratory alkalosis in these persons. You can see kind Stokes respiration. We are going to see what exactly it is. Then we can see increased erythropoietin production. Why it is important, you already know. Increased number of RBCs, increased blood volume, increased cardiac output, increased vascularity of the peripheral tissues, and alkaline urine. Cellular acclimatization. So there will be increased mitochondria. So increased cytochrome oxidase. Now see how the body is having a compensation to overcome the hypoxia effects. Now these all will be activated so that normal amount of oxygen will be delivered to the tissues. So respiratory system at the cell level and the cardiovascular system all will be activated, and they will try to compensate the effect of hypoxia. The muscle tissue also will show increased myoglobin. So all of them are just having that, making sure that normal amount of oxygen will be delivered to the tissues. There may be sustained hyperventilation. There may be prolonged hyperventilation. So if you are seeing at a particular level of a person who is acclimatized at higher altitude, who is going to reside at that particular things, you can see the persons are hyperventilated. Why? Because CO2 washout is there. That leads to respiratory alkalosis. So it gives this particular answer to the previous question. Why? Because there is hyperventilation in these persons that will wash out the carbon dioxide, and this leads to respiratory alkalosis. Now the kidneys will try to compensate this alkalosis, respiratory alkalosis, and they will give the alkaline urine output. And this tries to normalize the pH of blood and the CSF. So both of these mechanisms at the inner levels, they will try to normalize the pH of the blood as well as the CSF, and this can withdraw the central chemo-mediated respiratory depression. So all these will cause withdrawal of the respiratory depression, and the hyperventilation will be continued due to these factors. So we can see prolonged hyperventilation. So net result is that you will get a resting increase in the pulmonary ventilation. Generally it is seen to be increased by 5 folds, and it is due to increase in the tidal volume. This powerful ventilatory drive is also possible as there is increased sensitivity to the chemoreceptors and decrease in the work of breathing. So that makes the hyperventilation easy and less tiring. So along with this, these two changes are also occurring: increased sensitivity to chemoreceptors and decrease in work of breathing. So hyperventilation sustained and prolonged is possible. There is also seen as increase in the TLC, that is total lung capacity. So in Highlanders, evidence is relatively enlarged barrel-shaped chest is there, and that increases the ventilatory capacity in relation to the body mass. That also increases the diffusing capacity of the lungs, and it can lead to pulmonary hypertension. So increase in the total lung capacity, increase in the ventilatory capacity, and increase in the diffusing capacity. And all these can lead to hypoxic pulmonary vasoconstriction. Due to that, these changes are occurring and can lead to pulmonary hypertension. So there will be increase in the number of pulmonary capillaries also. See, so what are the long-term changes in the acclimatization? That whole of the body will give response genetically by increasing the number of enzymes, increasing the number of mitochondria. Now they are going to increase the pulmonary capillaries also. Increased vascularity of the tissues. So more capillaries will be open up in the tissues than at the sea level. So normally only 25% are open and rest are remaining reserved. But all these will be open. Growth of new circulatory capillaries can occur, which is termed as angiogenesis. And this combined with system vasodilatation, more oxygen can be delivered to the tissues due to these responses. The physiological polycythemia you have already studied. Hypoxia induces erythropoiesis. So increase in the hemoglobin concentration and RBC count will be there if you are staying around few weeks there at the highland. Expansion of the blood volume is there. Hemodynamic is kept within normal limit, because even if there is increased vascularity, the expansion will be increased and the hemodynamics will not be changed. There will be increasing in the amount of circulating hemoglobin. In spite of decreased saturation, the carrying capacity is maintained at normal limit. So all changes are possible here in the vascular system. Now coming to the serious changes. The cardiac output often increases up to 30% immediately and then gradually returns to normal in 1 to 2 weeks as the blood hematocrit increases, because the count now will be increased. Capillary density in the right ventricle muscle increases because there is a combined effect of hypoxia and excess workload on the right ventricle caused by the pulmonary hypertension. So we know that there will be pulmonary hypertension that causes excess workload, and these two factors is increasing the capillary density. So these are the changes. There was one word which was known as Chine-Stokes breathing. A separate question on this only can be asked. Chine-Stokes or Kine-Stokes breathing, it is known as. Above 10,000 feet, most people experience a periodic breathing during sleep. Repeated sequence of gradual onset of apnea followed by a gradual restoration of respiration. So there will be no breathing, again respiration, no breathing, again respiration. So these type of breathing will be followed. So above 10,000 feet it can occur, or abnormally also it can occur. So respiration may cease entirely for few seconds and then shallow breaths begin again. During the period of breathing arrest, person often becomes restless and may wake with a sudden feeling of suffocation. So the person is not able to sleep properly, and that disturbs the sleeping pattern. It is becoming exhausting for the climber. So generally acetazolamide is a drug which is given to relieve these particular things. So one of you can again in detail give one PPT for this Chine-Stokes respiration. So any roll number, I may be repeating same roll number again and again, but I would like to repeat 33. If he or she has not given up till now roll number 33 in details, you have to give one short homework regarding the Chine-Stokes respiration. So the clinical syndromes which are caused after discussing all these normal physiological changes, accommodation as well as acclimatization. Now we'll see after that also we develop some clinical syndromes and at high altitude which are known as hazards of rapid ascent. And that the first is high altitude pulmonary edema, which is HAPO, acute mountain sickness and chronic mountain sickness. So these three are the clinical syndromes. Again, a small answer question can be asked on these three. So what is high altitude pulmonary edema? It generally occurs above 10,000 feet. It is seen in 75 to 80% in persons doing heavy physical work in first 3 to 4 days. So without acclimatization, in generally immediately those who are doing work in first 3-4 days, they will have these particular things. Person who is acclimatized at high altitude stay at sea levels for more than 2 weeks, and again rapidly if he or she is reascending, then also there will be danger of this edema. Characteristics is life-threatening form of non-cardiogenic pulmonary edema due to aggravation of hypoxia. So our military persons, you might be seeing that many people, the military officers, they are doing some heavy work, heavy physical work at these particular heights. They do the roads also, tunnels also, so many things are there, and they always are busy in doing all this. And of course, the borders are also secure due to these persons. So they might be having these problems. Generally not developed in gradual ascent on avoidance of physical exertion during the first 3-4 days of exposures. So what are manifestations? The earliest indications are decreased exercise tolerance, slow recovery from exercise, the person feels fatigue, weakness and exertional dyspnea. Condition typically worsens at night and tachycardia or tachypnea occurs at rest also. Symptoms may be cough, frothy sputum, cyanosis, rales, and dyspnea progressing to severe respiratory distress. Other common features can be low-grade fever, respiratory alkalosis, and leukocytosis. In severe cases, an altered mental status, hypotension, and ultimately death may result. So these are generally the HAPO manifestations. How it is developed. The mechanism of development for this is sympathetic activation by physical work is there. is over, and above the sympathetic stimulation by hypoxia and cold. So now they are exhausted completely. That can lead to vasoconstriction. This increases the increase in pulmonary capillary hydrostatic pressure. So around 10 to 25 millimeters increase is seen. This increases in capillary pressure, drives the fluid out of the pulmonary capillaries. So it changes all the cardiovascular structure, and that develops the pulmonary edema. So this is the mechanism behind development of pulmonary edema. So you have to really see to this that all the persons, those who are at least having the duties, they have to have stay at some base camps. You must be hearing all these things, that they have to acclimatize at base level camps, and then they can start their work. How we can treat this? Standard and the most important is descend to lower altitude as quickly as possible, preferably at least 100,000 meters, and to take the rest. Oxygen should also be given if it is possible. Symptoms tend to quickly improve with descent, but less severe symptoms may continue for several days. So that this is immediately you have to shift that person to the lower levels, and if possible, you can give the oxygen. Acute mountain sickness is the second clinical syndrome. It occurs when person from sea level ascends to high level within 1 to 2 days for the first time. It develops within 8 to 24 hours and lasts for 4 to 8 days. More likely if there is rapid ascent, lack of acclimatization, and the symptoms generally are seen: nausea, vomiting, headache, dizziness, irritability, insomnia, and breathlessness. So these are the common symptoms. You don't have to miss any of these symptoms. These are common at the heights. You might be knowing that. But if these are the symptoms, don't miss these symptoms. Cause is exactly not known. Appears to be associated with cerebral edema. Due to decrease in the oxygen, arteriolar dilatation will be there, and that can lead to cerebral edema. Limit of cerebral autoregulatory mechanisms will be crossed, and that increases the capillary pressure, causing increased fluid translution into the brain tissue, or it can lead to alkalosis. In the minority of persons, more serious sequelae can occur. High altitude pulmonary edema can occur, or high altitude cerebral edema also can be developed. If remain untreated, it may cause ataxia, disorientation, coma, and finally death. And death may be due to tendorial herniation of the brain tissue. Treatment is high dose of glucocorticoids, decreasing alkalosis by giving acetazolamide. That decreases because that decreases the hydrogen ion excretion. The third condition is chronic mountain sickness. It occurs in long-term residents at high altitude. It develops polycythemia, cyanosis, malaise, fatigue, and exercise intolerance. There is extreme increased hemoglobin level, increased viscosity of blood, decreased blood flow to the tissues, and that leads to pulmonary vasoconstriction, causing hypoxic response, leading to pulmonary hypertension, and due to excess workload, there may be right ventricular failure. The treatment immediately return to the lower altitude at sea levels, and to prevent the rapid development of fatal pulmonary edema. So that is all regarding all these complications. This is a particular sign by our Indian Army at various sites it has been seen. 2 years back, I visited the Rohtang Pass, and I know that this is very dangerous to have these particular heights. I tried the level by walking also, and it was really very much difficult, and I can see that as actually I have felt all these things, that I know that the immediate reactions are really dreadful reactions. So really it's a hats off work of our Indian Army, that it's at these particular heights they are doing some so much exertive physical work, and everywhere these cautions levels are there. So I have clicked this photograph. Actually, this is not the height where I have been, but this is the photographs, the way are on the way completely, there will be these particular heights to give you alertness regarding this. So those who are interested can go again deeper in these particular points, and you can see in detail this high altitude physiology. So thank you very much. In the next session, I'll be dealing with much more height, that is space physiology. So thank you.